Hello class, my name is Blair Mayu, and this is my presentation on week 12's infectious disease presentation. And my topic is chlamydia and gonorrhea. So the agenda of this presentation will include the following: introduction to gonorrhea and chlamydia. I will go through them each individually and together throughout this presentation. Epidemiology, maternal and fetal risks of contracting these sexually transmitted infections, how the patient presents both subjectively and objectively, differential diagnosis, diagnostics, treatment, which includes prevention, education, and follow-up. So chlamydia trachomatis and Neisseria gonorrhea are both sexually transmitted gram-negative bacteria. They are commonly transmitted worldwide, and in addition, they commonly coexist together, meaning they combine together and can both infect a person at the same time. They are also both considered notifiable diseases, which means that it is required by law for providers to report cases to the government for surveillance of outbreaks. It is recommended that every pregnant woman be screened at their first prenatal visit, regardless of risk factors, because both infections are often asymptomatic in both male and females. So according to the CDC, chlamydia is the #1 communicable sexually transmitted infection reported and in the US, and gonorrhea is the second most reported sexually transmitted infection. So transmission. Gonorrhea and chlamydia transmission is by having vaginal, anal, or oral sex with someone who has the infection. However, it also can be congenital from when a pregnant woman gets the infection and transmits it to the baby during delivery. Women who have chlamydia during the time of delivery with a vaginal birth can pass it along to the neonate, as well as with a C-section if she's endured prolonged rupture of membranes. It is further noted that if there is an active infection at the time of vaginal delivery, there will be a 50 to 70% chance of passing it along to the baby. Gonorrhea is transmitted to the neonate in the same approach. And according to Spear and Armsby, it's known to be successfully transmitted in 30 to 40% of the cases. So chlamydia, maternal, and fetal risks of infection include an increased risk for preterm birth and premature rupture of membranes, as well as pelvic inflammatory disease. And for complications for the mother and future reproductive system, because past infections actually lead to tubal cilia loss of function and fibrosis of the fallopian tubes that lead to future ectopic pregnancies. For the neonate becoming infected, it includes risks of neonatal conjunctivitis, higher risks of pneumonia for 3 months after being born, and a higher chance for neonatal fatality. Interesting fact that the infants born in the US are actually administered erythromycin eye ointment as prophylaxis for both these infections. So gonorrhea, maternal and fetal risks of infection for the fetal and maternal risks that includes, again, preterm birth, fetal growth restriction, pelvic inflammatory disease. And just like chlamydia, if the mother was infected in the past, she has a higher rate of future ectopic pregnancies. And in the neonate, there are risks of the following infections: neonate conjunctivitis, which is the most common, blindness, polyarticular arthritis, genital infections, and meningitis. I actually work in a pediatric unit that's a step-down unit to our level 2 nursery. And I've actually seen many cases of bacterial meningitis in newborns from mothers infected with gonorrhea at time of delivery. So on to subjective presentation of chlamydia. So subjective presentation of gonorrhea and chlamydia are very similar, as they both can be asymptomatic and symptomatic. Asymptomatic patients may deny genital irritation and burning for chlamydia. Pelvic pain may deny occurrence of any abnormal discharge, but they will report having unprotected sex and or at-risk behavior that I mentioned before, such as IV drug use, exchanging sex for money, having multiple partners, or engaging in multiple unprotected sex. So symptomatic patients will often report the following: mild abdominal discomfort, vaginal discharge, bleeding after sex, abdominal exam tenderness, and dysuria. So subjective presentation of gonorrhea. Again, we have asymptomatic and symptomatic. The asymptomatic, the patient will deny any genital irritation, any pelvic pain, or any abnormal discharge, deny abnormal urination patterns, but patient does report having unprotected sex or at-risk behavior. Symptomatic patient will complain about abdominal tenderness, Bartholin's or Skene's glands tenderness, abdominal exam tenderness, vaginal discharge, dysuria, or urine frequency. Objective presentation of chlamydia and gonorrhea. So for both of these, they can be normal, or it can have one of the following for chlamydia: mild abdominal tenderness, fever, mucus purulent discharge from the cervix, abdominal tenderness during bimanual exam, and white blood cells on microscopic exam of the vaginal discharge, and a positive nucleic acid hybridization test from endocervical or vaginal swab. For gonorrhea, again, her exam can be normal or present with one or more of the following: lower abdominal tenderness, fever, tenderness in the area of the Bartholin's or Skene's glands, mucus purulent cervical discharge, and a positive nucleic acid hybridization test from endocervical or vaginal swab, or a positive culture. So differential diagnosis would be mucopurulent cervicitis, salpinginitis, and pelvic inflammatory disease. Diagnostics. So diagnostics used for chlamydia could be microscopic analysis of vaginal secretions, which actually used to, nucleic acid amplification testing, NAAT, from vaginal swabs or urine, or cultures of vaginal secretion, which is what I was going to say earlier, that used to be the gold standard, but it is no longer. For gonorrhea, a culture with the nucleic acid amplification from endocervical swab and or vaginal and first urine void. It could be from either one of those. And it is recommended to test for all STDs if they are positive for one or for both, because typically they'll have multiple STDs at the same time. So how to treat this? Recommended pharmaceutical medication for chlamydia is azithromycin 1 gram by mouth. And for gonorrhea, it is azithromycin 1 gram once by mouth, and ceftriaxone 250 milligrams IM together on the same day. And the CDC recommends to treat for chlamydia also when positive for gonorrhea. So education. We should be educating these women about the risk factors of sexually transmitted infections and encouraging them throughout their pregnancy to prevent complications, to get screened, and especially if they fall into this category, we want to be screening them multiple times. We want to educate them that all partners of the positive patient should be tested and treated, and abstinence from intercourse should remain until medications are completely finished. Really stress the importance of finishing the medication and being retested because it is highly likely that they can get reinfected. The importance for checking for other sexually transmitted infections. And patients should be reassured that with proper treatment and compliance with medication and the abstinence plan, that these sexually transmitted infections are curable. However, they must be warned of future reproductive complications. So follow-up, we want to retest these women in 3 months after treatment, and high-risk patients should be tested again in the 3rd trimester. And all pregnant women with pelvic, if they present with pelvic inflammatory disease as well as one of these infections, they should be hospitalized for antibiotic administration and observation for any complications due to known adverse pregnancy outcomes. And here are my references. I would like to thank you very much for watching my presentation on chlamydia and gonorrhea as infectious diseases in childbearing women. If you have any questions or need a copy of my references, please feel free to email me. Thank you.